Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, aloha once again, everyone. I'm Mike Buck, and happy to be the host of our program here for the Vein Clinics of Hawaii. You know, I'm glad you found us, and more people are going to be doing that as time goes on. Dr. Randall Juliff is the proprietor, owner, president, surgeon, does everything, and we'll find out more about that. But the Vein Clinics of Hawaii are located on our four main islands. Started on the Big Island, ironically enough. You've learned about that maybe on the last show. We'll talk about that some more. And then over the last several years as Osmost, and now he's on the island on the Big Island, on Kauai and Maui, and here on Oahu. And the procedures are fantastic. The following is terrific. And so he decided to come and meet you all and do a radio program. And I was thrilled. Some of you know that I've been doing similar programs in the past, a lot of different phases of medicine, and particularly because I'm not only a patient, but a believer in vascular health. Wow, I found out there's a lot of stuff to do. So what we're going to do today, and Doc sent me before the show started, sort of an outline of two programs. So by listening to us right now, you're making a commitment to come back next week and listen to part two. So this is the 6 classes of venous disease. And obviously, if there's classes, we need to find out where these classes came from. So, Doc, that's, once again, a pretty long introduction. But since we're talking about classes, we kind of have to talk about how these classes came about and why. How's about that for an opening line?
That's a good opener. Yeah, a number of years ago, and vein disease has been treated for many, many years, you know. And in this country, not quite as probably aggressively as in Europe, especially the Italian and the French. You know, it's phlebology, like we talked about a week or so ago, is the you know, the practice of vein care. And they had a much more developed sort of approach to it. Now, that has changed over the past 20 years here in this country. We've gotten, you know, much more in tune with the need, I think, for adequate vein care, adequate vein assessment. I think the impact, the health impact of vein disease on the population is becoming more and more recognized with time. And vein disease really has or was undertreated for many, many years in this country. Anyway, so as the growth or as the maturity of the whole art of vein care has come about, there was a need to have a common language.
Yeah, I was wondering if that was what was happening.
Yeah.
What are we talking about here? If I go to another country, another city, another island, wouldn't it be good if the doc that I was now going to knew sort of how I'd been diagnosed in the past?
Yeah. The the names and the words that people were using were a little too loose, and there was a need not only to communicate but also to be able to use those new classification form to better allow for the study of vein care. You know, how are we doing? You know, well, if a patient has this and we do that to them, you know, how do they move? Do they still go up to the next class, or can we make them go down, or do we stabilize in you know, a common nomenclature and verbiage for you know, what we were talking about was required. So you know, big thinkers and you know, people smarter than me got together you know, 15, 20 years ago and came up with a fairly extensive way to classify vein disease, from the least to the most.
So that's what we're going to do today. We're going to talk about from the least, start along this trail. One question that always comes up with me, and when I found out about these classes a few years back, I was wondering if sometimes it was also enabling for, say, an insurance carrier to know where somebody was, to find out how much of their treatment was going to be honored by whatever policy they had.
Oh, that happens too. Definitely. Yeah.
So, but I mean, does that help for the profession to let the insurance company know that we're dealing with this classification of patient, and to treat them, they must have this, that, and the other thing?
It does help, because the insurance companies obviously have their mandates, and if we can verbalize it to them in a very succinct and exact sort of way, they're going to cooperate. It's
pretty interesting. So I guess it's been tweaked around a little bit, and I'm wondering why there were maybe 6 divisions, because looking through the material you sent me, some of them are easier to explain than others.
Yeah.
Especially when it gets a little bit more complicated. Not this week's show, maybe next week's show. And I'm curious also, do some people just find themselves somewhere on this ladder permanently and don't get any worse and maybe don't get any better?
Well, we hope they get better.
Mm-hmm.
And they can. They definitely can. Especially the lower levels, once you get to the ulceration and that kind of stuff, I mean, we can improve. We can't make it perfect again, that's for sure. But by and large, we are looking to improve the status of people's vein function.
The thing that I like about this, and I know it's going to happen, gang, because I've been down a similar road, and that is, once you all find out about what we're talking about today, the first thing you're going to do is say, honey, does this look like this? And and I think what's kind of neat is now that it would trigger proactive responses by people. Everybody wants to see, well, what can I do? Do I have to do this all the time, or can I just maybe not eat butter anymore, or whatever whatever the thing may be?
Yeah.
So does this help people to realize at what stage of venous disease they are?
It does, absolutely, and whether they have it or not.
Sure.
Yeah. It helps tremendously to define a problem. And this goes for anything, quite frankly. But once you define a problem, you can recognize it and then do something to make it better. We've talked about this before. It's amazing the symptoms and the problems that people can ignore, and just chalk it up to age or other problems. And once we're able to again define the various ways that venous problems can affect your legs, it's like a light goes off in people's heads, and they say, oh, yeah, gee, I do have that.
What I was curious about, and we talked about this, if you weren't here with us last time, gang, I was talking to Dr. Juliff about something that was interesting to me, and that was when somebody says, I tingle, I itch, I hurt, I throb, I feel swollen, I feel heavy, and that all describes the same leg or the same vein. I'm wondering if it is kind of comforting for somebody to say, okay, this is kind of where it is, and is it going to get any worse, or how can it get better? Isn't that when we start here at the very bottom, the C1 and spider veins, that some people think, oh no, now I'm doomed. Look what's happening to my legs. Pretty soon I'm going to look like grandma.
Yeah. No, they don't have to.
They don't. Yeah, that's pretty good. So gang, so you understand it, and then there's another thing. Right now, we've all been more and more attuned with what's happening on the Richter scale, for instance, with all of these earthquakes, particularly to do with the lava flows on the Big Island. And there are 4 here, they didn't cause a tsunami, blah, blah, blah. I'm wondering if these stages are evenly divided, or is it just at a good juncture where we go from one class to another? Is there some overlap?
There's some overlap in that unfortunately the patients in the higher levels of the C classification probably have
a lot of symptoms.
Everything. Probably have everything below that too.
Okay.
Now, but the problems in general are addressed in kind of the same way, depending or whether they have 3 or 4 or whatever.
Okay, well, let's just plunge right into C1, and you've called C1 spider veins. We talked about them previously. We're going to talk about them a lot. Sometimes they're related to other problems, sometimes not. Is this a pretty good 101 place to start, to step off?
No.
Mm-hmm. What is before?
Actually, one thing that I didn't add to the list is there actually is a C0 classification, which means that there are no, when you observe the patient's leg, there aren't any physical signs. We call this the C classification, and the C stands for clinical.
Okay.
So clinically, what
C0 means the guy looks pretty good.
Yeah, it looks fine. Now, and that's important because of the fact that, and this is a hurdle that we often have to get over, that you don't have to have any of these, signs, obvious signs, to have venous insufficiency. Your legs may look perfectly normal, but you have, you've got achiness, heaviness, fatigue, muscle cramping, restless leg syndrome, all these other symptoms. But not necessarily physical signs. So, and there's a bunch of people out there like that who have no physical signs, but a lot of symptoms, and it's hard for them to even or understand or recognize the fact that they have a vein problem.
When you say symptoms, there's another question that I'm interested in. And sometimes you hear somebody, oh boy, that guy's he's a giant. He can handle pain. The pain's not a problem to him. I'm wondering if there are so many different ways that people can handle pain that sometimes it takes a long time for some individuals to have any symptoms they're afraid of because they handle it. It doesn't bother them. It doesn't hurt them. Where somebody else, you just touch the leg and they go, ouch, that hurts.
Oh, definitely. Yeah.
Wow.
People are very, very different. And, not only do people have different pain tolerances, but a lot of people want to ignore their symptoms, too.
Yeah.
They don't want to admit to themselves that they have symptoms. Now, this goes for, vein disease as well as everything else. But it's amazing what people try to deny that they have.
Yeah. Okay. So in the very beginning here, now that I've found out exactly the C0, let's get into a C1, the spider veins. I thought when Doc Juliff and I first met that this was the driver, that this spider veins, everybody goes to the venous guy and he says, or she says, I don't like this. I want to do something about this. Well, that might be partially true. It really is not the way that it is. But yet, I would think that a whole bunch more people have spider veins than not. When you said C0, I don't know anybody that doesn't have something on their leg, some little thing on their leg somewhere. Yeah.
I think by the time you reach 30 or so, you got something on your leg.
You've earned it. By that time, you've earned it.
You deserve to have something on your leg.
Of course.
Spider veins, they as we've talked about in the past, they can be sporadic. They're often genetic. They are always considered just a cosmetic problem, even though some people will say that they have some symptoms associated with spider veins, like a little achiness or they're tender. But in general, the study of phlebology recognizes them as cosmetic, as do insurance companies.
Are some people saying, look, I'm glad I know, now let's get rid of them? Because I don't like the way they look.
Yeah.
But it's good to know that they're not a sign of imminent failure in something that you've got.
No, and they're not always a sign that you have any other problem with your vein function. You can have spider veins and still have perfectly normal vein function of the other, the deeper veins in the leg.
And some of you are going to find that's going to be good news. The other of you are going to have to go to veinclinicsofhawaii.com and take a look at the website and see what's going on with all the different ways you can do this. I'm fascinated by the fact that a lot of people become aware of things once you are able to put them somewhere on this chart.
Sure.
Because I'm comforted. I mean, if you're a baseball player and you have a 200 batting average, if you can have somebody help you get a 250, you're overjoyed. Even if it's just for cosmetic looks. But I don't want people to worry that, oh, man, once you got one, you're going to go all the way up to 6. We're going to talk about that a lot.
Yeah. And that, just about every level, that is not the case.
Yeah.
Just because you have spider veins, you are not going to ultimately end up with, problems with your skin and ulcers and all that stuff.
Okay, are spider veins pretty much contained to the legs, or are they likely to show up in other areas on the body?
They can show up in other areas, and we treat those. People have facial.
I've seen facial and maybe some around the neck.
Yeah, neck. The areas that people don't want spider veins that sometimes they do, or head, neck, chest, back, torso, and we can inject or treat them in one way or another.
How many Doc? How many patients do you get that are referred by a spouse that say, I'm so angry because my husband's got this big piece of rope hanging off the back of his leg, but since he can't see it, he's never had it looked at. Here, look at it. Let's find out if there's anything going on here.
Yeah. Well, that is the case, and that goes for spider veins too. The spider veins that are the most bothersome to individual patients are those spider veins that they can see.
Gotcha.
And it's surprising the number of people who will actually say that. Like they come in and they say, geez, these spider veins on the front of my thigh, they drive me crazy. And I'll say to them, well, have you seen the spider veins on the back of your legs? They're worse.
Look at this mirror.
And they say, no, they don't bother me. I can't see them. So
I've always wondered. I love analogies, so we're going to use a lot of these. I always wonder why people put this big, very, very colorful tattoo on their back, because
they can't
see it. So I think out of sight, out of mind is how it goes with some of this stuff.
Sure.
And you said that a while ago that some people, they just have a penchant to get into denial, and that's all they want. But at some point in time, something must trigger either a symptom or an increased worse appearance. Might say, okay, I'm looking at something here that needs to get looked at. So when that happens, are generally people relieved to find out what you tell them with respect to what's next or how they can be treated?
Absolutely. Yeah. I mean, when they come in, again, it goes back to the definition of a problem. Once because the patients don't know. I mean, if they haven't studied this stuff, they don't know that one symptom or another may be due to a specific problem that can be dealt with. And I think that most people are very happy
once they find out that they've had treatment or they can get treatment. Do they think that there's an end to it? That I found Mecca. I found this Dr. Julep at VeinClinicsOfHawaii.com, and he's going to fix me. And I know that you're going to sit down with me and you're going to say, okay, we're going to fix you. But, it's not permanent. You have to understand that you have this for a reason. And we may not be able to cure the reason. We can help you the way they look a little bit, but what else?
Sure, yeah. Well, yeah, since a lot of it is kind of genetically caused, and, so people who have the genes, I mean, they're, predisposed to develop stuff. So yeah, we don't change that, but we do everything we can to fix the problem and make things look better.
You said that sometimes there are symptoms. I've had varicose veins and I've had them treated. I had no symptoms, but that doesn't mean that others don't. What would a typical example of a symptom be?
Well, for varicose veins?
No, for
spider veins.
Yeah.
Well, typically not much.
Yeah,
I mean,
much,
the vast majority of people do not have symptoms. Like I said, occasionally people will say, "Oh yeah, well I've got these spider veins over here, and they're achy, they're tender to the touch, and et cetera, et cetera." But unfortunately, they're all handled the same way, and we treat them, and sometimes those symptoms do go away.
Okay, so anyway, gang, enough of you. Many of you have already known about spider veins and the treatment thereof. And we talked about that, and we're always going to talk about that. But as you move out of there, I want to make sure that people understand that there are a few options for the treatment. It's not a one case fits all. So what is the most popular, and what are some of the others? As far as what do you do to help me make that spider vein disappear?
Yeah. The gold standard for spider veins on the legs, now this doesn't go for everything else, but on the legs is still injection sclerotherapy. So, and that's what we do for the most part. We inject spider veins.
And there's a couple of different solutions depending on the application.
Yeah, there's a couple of different solutions, and there's a couple of different ways to handle those solutions. And everybody's got their favorites, so it boils down to what works best for you.
And gang, by the way, we've talked about this and we'll always talk about this. It is way, way different It's like Papa's got a new pair of shoes. For the treatment and the size of the needle and all of the things that Dr. Juleff and the Vein Clinics of Hawaii use and other, more modern practitioners of this, it's walk in, walk out. I think that's really important for people to learn. No,
sure, yeah, it's definitely walk in, walk out. But some of the other things that can be done, or of the other things that can be done, and a lot, there are other people out there treating spider veins on the legs with the laser.
Sure, laser. I've heard of that.
And when you look at a large group of people, from a statistical sort of standpoint, injection sclerotherapy does a better job with eliminating spider veins than a laser does.
Do you think that maybe a lot of people jumped to the gun on the laser thing? That maybe it became, first of all, I don't want to say affordable, but available.
Sure.
And if you got a lot of patients getting treated, it can be, I guess, rewarding.
Yeah. Well, I think probably what it boils down to is, if only all you have is a hammer, everything becomes a nail.
Yeah. I want to tell you something. From what I understand, laser treatment is you're burning me up. The thing is going into my body and is cooking me.
Yeah.
Yeah. I don't know if that would hurt or not, but I don't want to find out.
Yeah. So laser from my experience with laser is that it doesn't people don't respond as well. Number one, number two, they come back a little quicker.
Yeah.
And number three, laser therapy for spider veins hurts more than injection sclerotherapy. Now, injection.
Note
is
to
not,
self: never mind laser for me in the future. Okay.
Yeah. You have to, when we're doing injection sclerotherapy, you have to put up with the little injections. But as you mentioned before, it's a tiny needle, and most people tolerate it fine. So now the one we do have a laser in our office, and the one situation that we might utilize laser for leg veins is as an adjunct. So we might
as part of the treatment.
As a second part of the treatment. So we might treat people with injection sclerotherapy and try to clear as much as we can. With the injectable medications, and then kind of go back after that and use the laser to kind of clean things up a little.
Gotcha.
And that has been useful. But there are other things too. I mean, there's electrical energy devices. There's radio frequency devices that can be used superficially.
It would tell me as a patient, Dr. Juleff, that it is enough of a concern, whether it's low self-esteem or whatever, that there are a lot of treatments, because there's a lot of people that have it that want to find out, okay, what's the quick fix? What's the most recommended? What's the most successful?
Sure. Yeah.
So, deal the cards. You pick your card out of the deck.
Yeah.
But you prefer to use the sclerotherapy.
Yeah. Well, in the world of vein care, most people, the overriding majority feel that injection sclerotherapy is the best way.
Okay, so we'll move away from spider veins at this point in time on this program, and don't worry. At any time, you can send a letter to the mailbag. You can contact us at veinclinicsofhawaii.com and leave a question or comment, and we'll get back to you. If you leave your email, we'll figure out a way to get back to you and let you know when your question will be addressed on this program. The reason why the program is going to be as successful as I know it is for C2. That's the next step of these 3 steps that we're trying to cover today in the program, and that is varicose veins. And the minute you say that, people conjure up a whole bunch of different things. What is varicose vein?
Well, varicose veins are enlarged, dilated veins that are not the problem. When people come in, what they see is a big bunch of varicose veins on their legs, and they want them gone. And they have symptoms, and they are assuming that they're coming from the varicose veins. But varicose veins are just another physical sign of an underlying problem with the function of the veins that are deeper in the leg, this thing that we call venous insufficiency. And what I have found is that it's rare that someone has varicose veins and not underlying venous insufficiency. Most of them do. So that's when C2, which as you mentioned is the second step in the classification. That's when the disease process becomes clinically important. Spider veins, not so much. They're cosmetic. They don't imply or suggest in a strong way that there's any problem with the functional status of the veins that are deeper in the leg. Varicose veins do.
Yeah, I think in once again, one of my analogies, when there's smoke, there's fire. And my first question always has been, are the varicose veins still working as veins? And the answer that I've always thought was yes, but not very well.
That is true. Yeah, there in varicose veins, there's blood in varicose veins. It's a rocking, rolling around in there.
Okay, so you know me, I'm going to bore in. Let's say that we get this varicose vein on the back of my leg removed. Yeah. Or where's the blood going to go next? I mean, am I going to make a new vein, or does it get shuttled off somewhere else? How does the circulation continue?
Well, in that goes to the treatment, but you have to remember. The varicose vein means that there's another problem that's deeper in the leg. So it's not just taking out the varicose vein.
Yeah, because you haven't got to what made the varicose vein.
Yeah, you haven't gotten to the root problem. So in the way that we get to the root problem is to do an ultrasound. And the root problem with people who have varicose veins, again, is this thing that we call venous insufficiency. And that means that the deeper veins in the legs aren't functioning, and that is almost always due to valve failure. There are one-way valves within veins. They can fail, and they can create problems with function. There are other situations, too. There can be obstructive-type processes.
And, gang, one of the things that we learned earlier, and I think we need to repeat this from time to time, what some of this does is not just becoming aware of it, but getting into treatment, because it's going to affect your lifestyle. And in many cases, because many of us are, as we learn out in every single time you turn on the radio, we have to work harder and longer. And sometimes when your body is starting to shut down and you put these extra loads on it, and if one of those loads is an amplified problem of venous insufficiency, you may be in for more trouble than you think. That's what I'm worried about.
Yeah. Well, and that's why I say that when people get to the C2 level, the varicose vein level, it becomes a medical problem. It's an important kind of thing that needs to be addressed.
See, unfortunately, and we've learned from previous programs, that of all the diseases that you could have, this one probably comes on the slowest. And it sneaks up on you like a bad guy in the middle of the night. It's all of a sudden, it's robbed you of something. Whether it's your mobility or your energy or your social life or something gets affected outside of just from your health standpoint, from your quality of life.
Sure. Yeah. The one thing that we hear a lot of is that people come to us and say, the symptoms, which again are, achiness, heaviness, fatigue, their legs get tired quicker than they used to. They feel like they don't have the strength that they used to, even though they don't have muscular problem. It's not a muscular strength problem, but they feel like they do. They can't do the things that they used to do or want to do. And, one of the big things that people tell us is that, I can't go to the gym anymore. My legs feel so bad, I can't get out and walk anymore. So not only is it a medical issue in and of itself, but it could be interfering with your ability to stay healthy globally.
Yeah, I have one for you, and this is pretty interesting. Friends of mine, a couple who live in our neighborhood, they found out, and they tried to pass it on to all of us, that we all eat too late. We should eat our dinners earlier. You should eat 6, 6:30, 5. You should eat a lot earlier. And what a lot of the folks in the neighborhood do, particularly in the nice weather, which is, the nicest on the planet right here, is they walk after dinner. And one of the guys doesn't walk. The wife will say, honey, let's go. Oh, not today, honey. My legs are killing me. I got to go elevate my legs. So now, not only is he being sedentary, but he's not burning the calories that he was on his walk. So it's a problem with a double-edged sword.
Absolutely. Yeah, absolutely. Not only do you have the symptoms from the vein problem and the potential risks for other things, But yeah, it interferes with your ability to stay in shape.
Is there any simple answer as to why they occur? I mean, I think we're going to go further into the leg and look at this venous insufficiency that you talk about. Does that manifest in a varicose vein a few inches away for some reason? I mean, is your body being shown something so that your doc can say, "Boy, you got some problems. We got to go ultrasound you."
Yeah, that's exactly it. Yeah. That is exactly it. The varicose vein is a sign, of that problem that needs to be heated, so yeah, absolutely. It's it's telling us that we need to look further because the underlying issue has to be addressed also. Yeah. It's not as easy as just taking out a varicose vein. You have to get rid of the venous insufficiency, otherwise another varicose vein is just going to pop up.
But I was asked this question years ago, and then I've asked it myself. Is let's say that you really want to go to the nth degree. You really want to get treated. You want to get rid of these bad veins. You want to get them removed and move along with your life. Can you just keep removing them? I mean, we've seen surgical things, and please address this one. I just thought about this. In other surgeries, sometimes people are taking veins out of your legs that are good and moving them into your heart. I mean, so it looks like to me that's a shopping center down there. So you must have a lot of extra veins.
You do, yeah. The veins that we treat, and ultimately what we're doing is we're closing those veins down. Are veins that you can do without. Yeah. Now we're closing them because not only we're closing them because they're working against you. It's not like, and a lot of people ask that question. Gee, if you close that vein down, am I going to be okay? And is my leg going to have the circulation that it needs? And the answer is it's actually going to be better because that vein is not working in your favor at this moment.
Are you making new ones?
Not as much as the good veins that are in the leg take over when you do treat the underlying problem.
I get it. Because I do know that there are some people, and like I said, we're aging in place, we're getting older, that if they have a venous condition that started in their 30s or 40s, and now they're in their 80s or 90s, they conceivably have had a lot of veins removed.
Sure. Absolutely.
But they still can walk around, which is a pretty good sign. Yeah. That's good news.
Yeah. They can walk around better than they were before.
Which is even better news.
But getting back to your point, and this is a good point to make so that people understand, and that is that, yes, the veins, some of the veins that we close in the leg over the course of treating venous insufficiency are the same veins that are used for bypass.
Interesting.
Heart bypass or bypasses in other parts.
Do the heart guys feel pretty good that there's a field of stuff that they might be able to use down there?
Yeah, well, not necessarily down there, but so occasionally people will know about that and will say, "Hey, doc, you're going to close down my vein. Yeah. What if I need
that later?
Yeah, what if I need that? Because my father had bypass surgery when he was 60, and I'm 59 now, and what about next year when I need heart bypass?" But the answer to that is, number one, there are other things that can be utilized in your body for heart bypass grafting, and usually, and most of the time, the other conduit or the other type of vessel that we use is an artery, an artery from the chest wall or an artery from the arm. These can be utilized instead of the vein from the leg, and the artery bypass grafts are actually better than the vein bypass grafts.
Okay, I think I have a dumb host question.
Okay.
And that is, as much as I think I know, I know very little. And so I'm a sponge. Like, I hope all of you out there are the same way. And please go to veinclinicsofhawaii.com and cruise around and see a lot of the things that the doc's involved in. And you're gonna get a feel that, like I have, that you finally found the right place to get some answers. You may not even need any treatment, but just to get some answers. And I think that therein lies the beauty of that. But my dumb announcer question is, we always talk about the veins and the valves. And I'm thinking if the arteries are just taking blood from the pump and shooting it down into your feet, there's probably no valves in the arteries.
That is correct.
I've learned something, see, because it doesn't need them.
It does not.
Because it's pushing out.
It does.
As a matter of fact, a valve would jam them up. It'd work against them.
Yeah. There's no need for a valve in an artery. And actually, we have valves in the extremities of our body. We don't have valves in the veins of the of the non-extremity portions of our
so
bodies.
above the torso, maybe.
Yeah. So so there is in those veins, blood flow is occurring just through a pressure gradient. But because of the fact that, again, we spend most of our life in an upright position, that just does not work in the legs because the blood's going uphill, and it's going up a hill against gravity. So it needs something like that.
It is amazing. Now we're told to have these ergonomic chairs and to roll around on the floor a little bit more. In other words, you're right. We are sedentary. A lot of us are victims to, I don't want to say victims, but we're inquiring minds. We get done with the full day's work, put those legs up, have a cold beer, and watch 3 hours of talk shows or news or anything else, and we're just not walking around like we used to anymore.
Yeah.
Okay, so but I think the ongoing question would be, all right, we know that we'll talk about the symptoms and talk about some of the treatment, but what's the question that people ask mostly about? Well, am I going to be able to return to my tennis, or am I going to be able to walk again? And what are the steps that you're going to take for me to help facilitate that, if that's my goal?
Yeah. The answer is absolutely. Yeah, that is the goal, to get people back to not only doing what they used to, but doing everything that they still want to do, and doing it hopefully in a more comfortable, efficient, aggressive sort of manner.
I want to tell you something. Since I got treated, I had this abject distaste for watering plants and doing stuff late in the afternoon. I wanted a sprinkler system that did everything. And now I find myself, because I want to go talk to my plants, that I turn the sprinklers off and I water these things by hand, which not only gets me off my backside watching television, but actually helps, and I eat early dinners, it actually helps me to just get that stuff out, so when I finally do go to bed, it's quality.
Sure.
So I think that isn't that part of it? Some people, tennis, to heck with playing tennis. I want to get a good night's sleep. My legs throb all night.
Mm-hmm. Yeah, sure.
Okay, so once let's talk about the process that you use to diagnose at what level my varicose veins are in order to come up with options, treatment plans.
Sure. Well, when somebody comes into the office with varicose veins, and we describe to them what is probably happening, and the main diagnostic tool that we use these days is an ultrasound machine, which has gotten fabulous with respect to the quality of the images that we can obtain from using an ultrasound machine. And especially with respect to looking at the vein function. So, ultrasound has gotten so good that when we're doing the ultrasound on veins, for instance, we're looking for abnormal flow patterns, and we can actually see.
I love that. And here's a question that I asked Gang when I was down at Dr. Juliff's office. It seems to me that this is opening a category of expertise, so that more and more vascular surgeons like yourself need to have a really good ultrasound person that really is looking at every set of legs with the same eyes. And so when they come to you and they say, it's like if you're in a dentist chair and you think there's no communication, and the hygienist is saying to the doc, 27C, blah, 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 blah. That's what she's noticing cleaning my teeth. I almost don't want her to clean my teeth because I don't want to find out. But isn't that also a real skill? And aren't there great opportunities to get to be up the food chain in that category, in that a technician job is.
Oh
what it is, right?
Yeah. It has become very much a specialty. Not everybody that knows how to do an ultrasound, on your gallbladder or whatever,
sure.
knows how to do vascular ultrasound. So that's a real expertise, and especially in the world of veins, there are good techs and there are not so good techs, because it's a real art.
Well, that's what I was getting at. What I'm saying is that, right now in medical terms, and we talk about this all the time on a lot of shows, and that is you have a primary care physician who's kind of really a quarterback. I mean, they're just diagnosed. They're helping you get diagnosed. They're not going to do your vascular surgery, but they're going to send you to the vein guy.
Sure.
And the vein guy is going to have his technician who is specifically trained in ultrasound for veins, not for gallbladder or headaches, And so it must be a wonderful tool for you to walk in and say, okay, well, what do we got here? and they say, well, I got this and that on this one. Take a look at this, and there it is. There's a picture for you.
Yeah. Just about any specialty or subspecialty of medicine uses ultrasound in one way or another. But with respect to practicing vascular surgery, I mean, you just can't do it anymore without the ability to do ultrasound.
And maybe in some areas it's nice to have, but what you guys do, it's must have.
Oh, yeah.
Only because it's available.
Well,
I mean, if it wasn't available, you'd figure out something else. But why bother?
And it's not invasive.
Yeah.
Before, we had to do venograms and all this sort of stuff, and which is an invasive procedure.
Hey, by the way, gang, I was a little bit nervous about that, and the worst part about it was cold. Yes. Not for very long, because there's some like gel stuff or something, right?
Yeah, you have to use gel, and it's cold when it comes out.
It is truly amazing. And I forget, but are there how many different points on the leg is a ultrasound person looking at? Must be lots.
Yeah, well, yeah, it is a lot. I mean, we look at both systems of veins. We haven't really talked about this, but there's actually two systems of veins, what's called the deep system and the superficial system. But we look at every vein in the leg, because any of them could be contributing to the problem. We look at the deep system, but there's a number of different superficial veins that we look at that often are problematic and have to be addressed.
Okay, when we talked earlier about spider veins and symptoms and maybe pain and whatnot, I think we've gotten into a category now where in the venous part, in the varicose veins, that there are symptoms that are maybe even for some excruciating. So, I mean, is that another thing that drives them? Drives a patient to a doctor saying, I didn't even care about what it looks like. I'm tired of it hurting.
Yeah. Sure. Yeah. There are the usual symptoms that happen when people have varicose veins and venous insufficiency, and those are aching, heaviness, fatigue, muscle cramping, throbbing, all of those. But there are also acute type things that can happen, things that can happen suddenly. For instance, there is something called superficial thrombophlebitis.
Superficial thrombophlebitis.
Very good.
I can spell it, but I don't know what the heck it is.
In what basically we, most people refer to that as phlebitis.
Yeah.
So people often will come in with that complaint. That can be a presenting complaint.
Is that the one they call the Richard Nixon affliction? Phlebitis?
I think it is, yeah.
That's what I remember.
Now that you mentioned that, yeah.
It used to lay them up. I mean, it was a big problem.
Right. So, you can, and this happens in a varicose vein. So when you have varicose veins, you mentioned the function of varicose vein, and, is there blood moving in it and all this sort of thing. And there is blood, but it's not moving very well. And it can be very, it can become stagnant. And when the flow is very, very low, there's a good possibility that it might clot.
Now we're talking deep vein.
Well, no.
What?
No, that's
the clot.
Deep venous thrombosis.
Yeah. Okay. Wait a minute. Now the clot's the one that if it starts in your leg in a varicose situation, if it goes unchecked, it could go somewhere else.
It could.
Yeah.
Well, that depends on what you mean by go somewhere else. It doesn't typically, a superficial venous thrombosis does not break loose and then go up to the heart and lungs.
Okay,
and all
or brain or whatever.
Yeah, that's a deep venous thrombosis. Okay. That happens in the deep, bigger veins.
I'm relieved because I don't want one of them.
No, you don't want either one of them.
Neither. Yeah.
But the thing with SVT, superficial venous thrombosis or phlebitis, is they occur suddenly. And again, many people will present to us with that as their primary complaint.
Yeah.
They'll come in and they'll say, "Hey, I got this lump on my leg.
Yeah.
It's red. It's tender. It hurts a lot. What's going on?"
I consider those people blessed, because if they got off their to come and get something looked at, it's going to show them some other things. They may not be prepared for them, but it's better to know than to not know.
Right,
Yeah.
right. And yeah, that's then we go into, the whole topic of what's going on, and often it's surprising, but yeah, you're right. It does at least give them the reason to come in. I mean, it alerts them to a problem that they don't know what's going on, but we help them define it, and then we treat it. But the other issue with SVT or phlebitis, sometimes in some people that can, propagate and lead to a deep venous thrombosis, the thing that you mentioned before, which then the situation becomes much more dangerous and concerning, because a DVT can break loose, become dislodged and come up to the heart.
And that's why, folks, you're seeing more and more of the TV ads or all these wonder medicines they're talking about. They'll quite often now mention that, not as a scare tactic, but certainly as a precursor of things that are possible if you don't get treatment.
Sure.
Before we have to, and we're going to be coming back to a lot more on varicose veins in other shows, but basically the treatment for a spider vein is to sclerotherapy, right? To
Injection
inject
sclerotherapy.
What about the treatment for varicose veins?
Well, twofold. You have to. There's two things you have to address. You have to address the reason that the patient has varicose veins, and then you have to treat the varicose veins. So, and again, it goes back to the valve problem in the deeper veins. So, we do to treat venous insufficiency, we do something called endovenous ablation.
Okay.
And that's us closing the vein down.
Closing that vein down.
And because the valves are so tiny, it's not like we can surgically repair them. And it's just easier and better for the patient, easier on the patient, if we just close the vein down. Now, when we close the vein down, then we reroute the blood flow.
That's the question.
Yes.
You close the vein down, but you're going to reroute the blood flow so that it continues.
Well, so that it continues to go in the right direction.
Exactly. Yeah.
When a vein becomes insufficient, again, those valves are failing in the blood rather than going up. Veins are supposed to carry blood up back to the heart. So veins in our legs should be carrying blood upward on the way back to the heart. As the valves fail, the blood actually starts to go downward. That's what we see on ultrasound. So when we close that vein, and there's a variety of different ways that we do it, we don't need to talk about that right now, but we do endovenous ablation. We close the vein. In the blood then that would otherwise be going through that vein, your body essentially automatically reroutes that blood, and it goes into healthy veins and comes back up the heart.
Well, there must be somebody in logistics in there that's doing a good job working overtime, right?
Absolutely.
Yeah. Okay, now.
So that then treats the underlying problem. Then we address these varicose veins. The way that we do it is to do something called microphlebectomy or ambulatory phlebectomy. And we just use little needle puncture sites through the skin. We don't make big incisions anymore. That's a thing of the past.
That's a thing of the past, right?
And we have special instruments that we're actually able to remove the varicose veins. So I
think it's amazing. So that means it's a little thing that you can hardly see, but it has the ability to grab something and take it out.
Yeah. It's a little. It looks like a little, like if you're knitting or something.
Knit one, pearl two. It's one of those
exactly.
things.
That's what I repeat to myself when I'm doing it.
Making a sweater.
It's a little hook. We call it a vein hook, and it works very well.
Okay, so that now, and like Dr. Jules said, we're going to spend a lot of time on this program talking about these varicose veins, because that's kind of the main thing. I mean, the spider veins are one, and then at the other end, which is a much smaller population of all of us out there, they get this other stuff at the end. But I think that when we go, you mentioned earlier, one of the things that it causes these bad veins is swelling, and everybody, and I know that's the next phase. C3 is swelling or edema. I know what edema is. I got it in my legs. And it's something that I have to live with, and I do. And there's going to be ways that doc's going to show us how to treat that. But isn't swelling the number one sign to the doctor, of, okay, this guy is swollen. We have to find out why. What part of inside this guy's leg or this gal's leg is causing this swelling?
Sure. Yeah. And yeah, like you said, it's the next level in the classification of the whole venous disease complex. But what does that and what does that mean? Well, that just means that there's a little higher level of venous insufficiency and a little higher level of abnormal vein function. Probably it has gone on.
Yeah, maybe for a long time.
A little longer than the C2, for instance. The difficulty that we have with swelling is that it's not always due to venous insufficiency. Often it is.
Yes, but in other words, it's a process of elimination. It could be, but it doesn't have to be.
Right.
So you're going to perform some sort of diagnosis to determine.
Well, from our standpoint, we do a venous ultrasound,
right,
and see if they have abnormal vein function. But you also have to consider other things. For instance, does the patient have some fluid imbalance or electrolyte problem, or does the patient have heart condition or lung problems? Or,
we talked to diabetes. We talked about a lot of things.
Are they retaining fluid for half a dozen different reasons? And then there's also the issue of lymphedema, which we've talked about, and sometimes it plays a co-role in causing swelling, but. From a venous insufficiency standpoint, it's the next step up. It's a further progression of the whole process of venous disease.
I'm going to guess that many of us that are maybe you all that are listening, me, I know a little bit about myself. I think that sometimes when you have that, it's more easy to admit. I don't think I'm supposed to be swollen like this all the time.
Yeah,
so
right.
Let's go find out. I had too much coffee, or I didn't. Once all you've eliminated that, and your legs are still swollen. There's something going on.
Yeah. Sure. Yeah, you got to figure it out. And you were talking about how the classes kind of overlap and all that sort of thing. And just because you have C3, which is edema, swelling, that doesn't mean that you have varicose veins and spider veins. Many people come in with a primary complaint of swelling.
Yeah.
And they don't have a varicose vein on their leg.
Wow.
Yeah.
But once you start looking inside, you find, well, these might not be visible, but they're there. I think it's I don't know if it's comforting, but it's certainly educating when the patient is proactive. Particularly, I've seen my veins on the ultrasound. It's like when somebody tries to find out the sex of an unborn child, right? This is this is what's going on in here.
Mm-hmm. Yeah.
It's fascinating. I think it's really neat because in all that you do at the vein clinics of Hawaii, and most of the time the patient is awake and aware. And I think that's a really gratifying thing for patients.
Yeah, well, and especially during the ultrasound, people like to see that. And we try to explain it to them when we're doing the study.
As a final question on that, particularly with swelling, because we're going to move on to promoting what's going to happen next week on the show, the next 3 stages, skin changes and healed ulcers, and then active ulcers. These are the real bad guys. But I'm guessing that the swelling part, if you're swollen, something's going on. It may not be deep vein problems, but there certainly is something going on, because isn't the body saying, this really hurts, so look, I've gotten it all swollen up so I can protect it?
Yeah. Well, I don't know if it's a protective thing, but...
maybe it's my body saying, I don't know what else to do, so I'm going to get swollen.
Yeah. Well, the one thing is for sure, there is always a reason for it. Yeah. It's not normal. It's and again, it goes back to all of these symptoms. And I can't impress upon people enough that if you're having any symptom, swelling and pain and fatigue, etc., chances are there is something wrong, and which is a good thing, because that means it can be corrected. And we can eliminate most of those symptoms.
There you go, my friend. So that's what we want to run up the flagpole. That's going to do it for this week. We want you to go to veinclinicsofhawaii.com and find out what Dr. Juleff and his gang are doing over there. And remember, it's you have a lot of different ways to get this treated, and we want it to be done properly. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.